Visible. You are
So,
audible.
okay. So the topic given to me is management of the first line options in renal cell carcinoma, with special focus on avelumab plus exitinib. So, as far as systemic treatment of advanced renal cell carcinoma is concerned, till few years back, we only had options of VEGF tyrosine kinase inhibitors. But since last couple of years, with the advent of the role of checkpoint inhibitors in advanced renal cell carcinoma settings, we have seen a paradigm shift in the management of metastatic renal cell carcinoma, with various options like IO plus IO combinations, as well as IO plus TKI combinations in the first line management of advanced RCC. So if we see prior trials of tyrosine kinase inhibitor, what we got was a response rate of about 20 to 30%. And if we see the overall survival figures, we got a median overall survival of about 20 to 30 months with tyrosine kinase inhibitors. So in the first quarter of 2019, we got the results of Javelin renal trial, which was published in NEJM, and that showed positive results of a PD-L1 inhibitor, that is avelumab, along with VEGF receptor tyrosine kinase inhibitor, that is exitinib. Okay, so if we see the trial design, very well conducted study. It was a phase 3 trial. If you see the eligibility criteria, it included patients who were treatment naive, advanced RCC with a clear cell component, having more than or equal to one measurable lesion. The tumor tissue should be available for PD-L1 staining. So PD-L1 was done using SP263 clone by Ventana platform in this particular trial. And patients should be having a good performance status of either 0 or 1. And the patients, they were stratified based on the performance status and the geographic region. They were randomized 1:1 to either avelumab in the dose of 10 milligram per kilogram every 2 weekly, along with exitinib, the dosing of 5 milligram oral to be taken twice a day, versus sunitinib. The schedule of sunitinib was 4 weeks on, 2 weeks off in this particular trial, 50 milligram oral. And if you see the outcome measures, the primary outcome, the primary endpoint was progression-free survival and overall survival in patients with PD-L1 positive tumors. In the key secondary endpoint, where the progression-free survival and overall survival in the entire population. And there were certain additional secondary endpoints like objective response rates, time to response, duration of response, and safety as well. Now, before moving towards the results of this particular trial, let us see the rationale of combining a checkpoint inhibitor along with a VEGF receptor. So as we all know, renal cell carcinoma is a vascular tumor in which VEGF plays a very key role. VEGF, it leads to immunosuppression. Whenever we are giving a TKI which is against VEGF receptor, so it may enhance the T cell mediated cytotoxicity, and that can be further increased by giving checkpoint inhibitors. So there can be a synergistic action if we combine a checkpoint inhibitor along with a VEGF receptor TKI. So that is the basic rationale behind combining an IO agent along with a TKI. So if you see the overall population breakdown according to the prognostic risk criteria, the two most commonly being used, the IMDC and the MSKCC, about 20% were of the favorable risk group, and about 60% were poor. And if you see that, if you combine the intermediate and the poor one, about 70-75% were intermediate poor, and about 20% were of the were in the favorable risk groups. Now, if we see the median progression-free survival in the entire population, in the overall population, so that favored the arm of avelumab plus exitinib. 13.3 months was the median PFS versus 8 months, and it led to a 31% reduction in the risk of disease progression. an absolute improvement of 5.3 months. So these were the results in the entire population. If we see the primary outcome measure, that is the progression-free survival in the PD-L1 positive population. So it was 13.8 months versus 7 months in the favor of avelumab plus axitinib arm, with a 38% reduction in the risk of disease progression, an absolute improvement of 6.8 months. If you see the forest chart, nearly in all the subgroups, they had a benefit with this particular combination arm. Very important, if we see the response rates in the comparator arm, in the sunitinib arm, the response rates are about 27.3%, and in the avelumab plus axitinib arm, the response rates were 52.5%. So we can tell near doubling of response rates, which can be seen, which can be noted with this particular IO plus TKI combination. If you see the waterfall chart, it shows a very nice waterfall chart in favor of the combination. 52.5% for the confirmed overall response rate. The median time to response was 2.7 months versus 4 months in the sunitinib arm. So that is, the response rates are really in favoring the IO plus TKI combination, along with the duration of response. So if you see an endpoint, that is PFS2, which is considered to be as a time from the date of randomization to discontinuation of the second line treatment or death from any cause, whichever occurs first. So it is in favor of the avelumab plus axitinib combination. If you see the charts, they are quite separate from each other. In the experimental arm, it is not yet disclosed, versus 19.4 months, with a 45% reduction in the risk of disease progression or death. Overall survival, only the interim analysis has been done. And till now, it is in favor of avelumab plus axitinib combination with hazard ratio of 0.79. And if you can see the curves, they are separating quite early, and they are still wide from each other. If we analyze the patients who received the subsequent therapy in this particular clinical trial, nearly 31% of the patients in the Bavencio group, in combination with axitinib arm, they received the subsequent anti-cancer drug therapy, compared with 51% in the sunitinib arm. If you see the adverse events, nearly everybody had any adverse events. The most common being diarrhea, hypertension, and fatigue. But again, grade 3, grade 4 adverse events were very less in Bavencio with axitinib arm. So the same toxic effects which were expected out of any checkpoint inhibitor. Now, if we, what do we have options as far as checkpoint inhibitor are concerned in renal cell carcinoma? Either we have option of a combination of an IO plus IO, that is nivolumab plus ipilimumab, or we have options of using IO plus TKI. In this particular group, we have various options like what I have just mentioned, that is avelumab plus axitinib. We have option of pembrolizumab plus axitinib. We have option of nivolumab plus cabozantinib, and we have option of lenvatinib plus pembrolizumab. So these are the various options we have as of now for the management of aRCC. So if we see, if we compare IO plus IO strategy versus IO plus TKI strategy, we can see that early responses are expected with the IO plus TKI strategy rather than IO plus IO strategy. As shown in this chart, the Checkmate 214 PFS chart, it shows that the separation of curves are quite late with IO plus IO strategy. So this strategy is not useful when we want a quicker response. So not suitable for bulky tumor or case where rapid response is contemplated. In contrast to what we see in a strategy using IO plus TKI, where we can expect an early separation of curves as shown in the Javelin trial, where we can expect the curves to be separated as early as about 2 months. So now some points regarding exitinib. So what is a special characteristics, or what are the USPs of this particular molecule? One thing is that it's a very selective inhibitor of VEGF receptor, unlike the other TKIs. So having very few offshoot target effects. It is having a very short half-life. It's having even the shortest half-life amongst the all other TKI, just 2.5 to 6 hours. And that is the reason why it is having a quite manageable safety profile. So if we see what short half-life does is, it leads to, it supports the combination therapy. Even there are various overlapping toxicities amongst checkpoint inhibitors and tyrosine kinase inhibitors. And in such a scenario, also a short half-life TKI is better. Even the time to resolution of grade 3 adverse events will be faster because of the shorter half-life with exitinib. And as I told, it's having very few off-target effects. It's a very specific TKI targeting the VEGF receptor 1, 2, and 3, and very few off-target effects. So, this is, if we compare all the trials of IO and IO TKI, we can see that if we see the response rates, it is not appropriate to go for a cross-trial comparison, but if we see the response rates across trials, what we can see is the response rates with a combination of lenvatinib plus pembrolizumab is the tune of about 70%. Numerically, it is considered to be as the most strong compared to the other approaches. If you see the median progression-free survival is about 24 months with the lenvatinib plus pembrolizumab combination. And the largest follow-up till now is with nivolumab plus ipilimumab. So these were the salient points which I wanted to highlight. Okay, if we see the side effect profile, if we compare the side effect profile of various such approaches, avelumab plus exitinib seems to be most tolerable. If we see the discontinuation rates, they are very, very less compared to the other approaches. If we see the dose reduction rates, they're also very, very less as compared to the other approaches. So as you can see, if you see the usage of corticosteroids in nivo plus ipilimumab, the use of high-dose corticosteroid for immune-related adverse events management were 35% versus 11% with the avelumab exitinib versus 27% with the pembrolizumab combination. So the usage of high-dose corticosteroid is very, very less with the combination of avelumab plus exitinib. And even you can see the very lesser rates of discontinuation because of treatment adverse events compared to the other approaches. Okay. So what after first line? So as we all know, these are the important trials in post first line management of the advanced aRCCs, where we have a good amount of data with everolimus, exitinib was compared with sorafenib, cabozantinib was compared against everolimus, nivolumab versus everolimus, lenvatinib plus everolimus versus everolimus. So these are all the important data sets which we have post TKI, post first line therapy. And we see, if you see the data part, the data of cabozantinib is fair enough. The data of lenvatinib plus everolimus in the second line is also good. Data of nivolumab is also there. So this can be used, this can be reserved for later lines as well. So there is basically no any clear advantage. There are no any head-to-head trials as of now to compare which approach is better. There can be various factors which one can consider in choosing the combination for our patient. It depends on what's the treatment goal, what is the toxicity profile of the combination, what is the frequency of infusions, the half-life of TKI, efficacy versus safety needs to be balanced. What are the options which are available for the second line post progression? So these all factors need to be considered. So as far as this particular trial and this particular population of nivolumab plus axitinib is concerned, it leads to a longer median PFS with 31% risk reduction in the overall population. 13.3 months was the median overall survival, median PFS in the overall population versus 8 months. Nearly twice the response rates were expected, about 25% versus 50%. There were very fewer discontinuation rates with this combination. It had a consistent PFS benefit across the subgroups. The median time to response was faster with this combination, and this combination was considered to be as safe. Very few high dose corticosteroid usage was considered if we compare the other trials as well. The dosing part, it's given as 800 milligram IV infusion over 1 hour, be given every 2 weeks. Axitinib dosing, the starting dose is 5 milligram twice daily, and then it can be titrated upwards to 10 milligram twice a day, having a close look at the blood pressure of the patient as well. So I think that's it. I again thank the organizers for giving me this opportunity. Thank you.
So thank you, Kshitij. That was wonderful presentation, and like you have covered very confusing area, like there are multiple options and multiple choices of basket, out of which we have to choose one. So you tried to explain how we should choose that, but still, so it will remain myriads of choices there for first and second line of RCC. So as far as I just want to ask, like out of all IO agents, your experience, and if there any difference in toxicity profile and your preference in first and second line.
So again, first line metastatic RCC, the patient is in favorable risk group. In my practice as of now, I still use either sunitinib or pazopanib in the favorable risk group. But in the intermediate or poor risk group, I do counsel them for checkpoint inhibitors. Seeing the data, I see.
Just to interrupt once. So,
yes,
like
yes.
As you have told that obviously we see hence risk stratification and these good risk and poor risk, but if we see NCCN guideline, they don't consider that risk stratification anymore, and they give everything to every patient. What you say?
Yeah, definitely. That is going to be the future as well. But as far as the practicality of giving checkpoint inhibitor is concerned, I think it is still better to look at the risk profiles and then to choose our decision.
Yeah. So obviously, very temptly say that we should use this risk stratification more oftenly. And every patient of RCC, first we should stratify our patient whether we should go ahead with TK alone or TK with IO or IO-IO. So as per my experience, we have used avelumab with axitinib for few of our patients in RCC in first line, and avelumab as per maintenance drug for urinary bladder for after first line if patient is in CROPR. So if I want to compare, like not much experience, but still out of all IO agents, avelumab is a good drug, no much toxicity issues, and like good responses. So as I've told that more experience should be there to quantify that statement, but still. So with this, we will thank you, Kshitij. We will go on to next session.